Welcome back, everyone. This is the afternoon session of the second International Cerebro-cardiovascular Medical Innovation Summit 2025. I'm Calvin Lau. A very good afternoon to you all and to our virtual attendees as well. Trust you all had a refreshing break just now. First up is session 2, Medical Imaging and Community Healthcare for Cerebro-cardiovascular Health Management. The chair for this session is Professor Peter B. Barker, and the moderator is Professor Chunyi Zhi. We will be welcoming them to the stage shortly for the roundtable. But to begin with, I'd like to invite our first speaker, Professor Peter B. Barker, Professor of Radiology and Radiological Science at Johns Hopkins University, who will be talking about molecular MR imaging in the human brain, current status and future directions. Over to you.
Thank you so much for the invitation to come here. It's my first visit to Hong Kong, and it hasn't disappointed. It's a wonderful city. I'm very happy actually to see at this conference actually so many people either from Johns Hopkins or affiliated with Johns Hopkins in some way. And I hope this is a collaboration that we can keep going in the future and strengthen it. So particular thanks to Dr. Kenny-chan for the invitation to be here. So I'm going to talk today about molecular imaging. And when we think about molecular imaging metabolism, it's really something totally different from the sort of structural or anatomical information, which for the most part is what you get from MRI scans. So it's really totally complementary, I would say, to a lot of conventional imaging. If we look at, let's see, trying to advance this slide. Okay, there we go. If we look at ways of getting metabolic information from MRI, there's a few different ways to do it. Obviously, CEST MRI can give a lot of information on tissue metabolism. We have a lot of experts, and I think we're going to hear much more about that this afternoon, so I'm not going to mention CEST any further. So I'm going to be talking about basically my own interest, which is MR spectroscopic imaging, or MRSI. If we look at MRSI, there's several different nuclei that can be used to get metabolic information. So obviously there's the proton, which has the highest sensitivity because it has the highest resonance frequency and it's 100% natural abundance. There's also phosphorus, which is 100% natural abundance, but somewhat lower sensitivity because it's lower frequency. And then we have nuclei such as carbon-13 or deuterium, which again are lower frequency still, and low natural abundance, so 1% or less. Actually, the low natural abundance can be used as an advantage because you could administer an isotropically enriched substrate and watch the buildup of the label, which is something which harder to do with the high natural abundance nuclei. So just a couple of examples from the literature. So deuterium metabolic imaging, which is becoming quite popular. Here, deuterated glucose is administered. It can be drunk orally by the participant. And then a little bit later, they can go into the scanner and you can make images of the glucose uptake itself in the brain, as well as its metabolism to glutamate and to lactate. And here you can see in this example of a brain tumor, there's decreased production of glutamate and increased lactate in the tumor. You can get similar sort of information with hyperpolarized carbon-13 spectroscopy, carbon-13 pyruvates being the most commonly used tracer so far. Again, you can look at the metabolism, in this case from pyruvate through the TCA cycle, and you also make maps of lactate, and in this case, bicarbonate. So both of these are quite powerful techniques, but they're not easy to do. You need special hardware on your MRI scanner. You have to administer an exogenous substance. And in the case of hyperpolarization, it's quite an undertaking to make the tracer and rapidly deliver it and image it in the patient. So it's actually, this is one of the few examples I could find in the literature of hyperpolarization in the human brain. So if we look at the natural abundant nuclei, there's two main ones. There's phosphorus 31. Here is an example here. You can see these nice phosphorus spectra with signals from compounds like ATP and phosphocreatine, phosphomonoesters, phosphodieesters. And you can do this at a spatial resolution of perhaps about 2 centimeters. But it's hard to get higher resolution than that because of the low sensitivity of the phosphorus nuclei, also the relatively low concentration of these phosphate-containing compounds. So the technique I'm going to talk about for the rest of this talk is what I like to work with, which is proton MRSI, which I think has a number of key advantages. First of all, it's the highest sensitivity. You don't have to give any exogenous substance, and you can do it on pretty much any high-field MRI scanner because it's obviously the same nucleus that is used for MRI. So just a sort of refresher, for those who may not be familiar with this, but this is a sort of typical spectrum you get from the normal human brain. There's something like 7 compounds which you can easily detect from this spectrum. And if you try a bit harder and start looking at all the little small signals in the spectrum, there's as many as 15 to 20 compounds that are potentially accessible. So there's compounds like NAA and glutamate, which are predominantly in neurons. There's compounds like choline and myonositol, which are predominantly in glial cells. And then there's also compounds like glutamine, glutamate, part of the TCA cycle, and phosphocreatine and creatine energy metabolism. So there's a lot of metabolic information in these spectra. This is a single voxel spectrum, so you pick one region of the brain. In this case, it's about 2 by 2 by 2 centimeter size, and in about 5 to 10 minutes, you can get a nice high-resolution spectrum like this. Now, what happens in the context of cerebrovascular disease? So this is an old paper from 1987. This was done in the gerbil with either unilateral or bilateral occlusion of the carotid arteries. And in this model, they could simultaneously measure blood flow, and they on the x-axis, I can't point out there. Okay, blood flow down here, and on the y-axis, they're looking at the lactate to NAA ratio. And basically found that once the blood flow dropped below about 20 mLs per 100 grams per minute, the lactate signal shot up. And the reason for that is because normally glucose goes through pyruvate, acetyl-CoA, and into the tricarboxylic cycle, but it needs 6 oxygen molecules in order to go fully around the TCA cycle. It's a very energy efficient process that generates 38 molecules of ATP. However, when the oxygen supply is reduced or cut off altogether, as you have in total ischemia, this pathway is no longer available. And so the alternative metabolic pathway is to go from pyruvate to lactate, which is relatively inefficient. It only generates 2 molecules of ATP. But that is basically why when the blood flow drops below a certain level, you start to see this lactate signal. So the lactate is sort of a marker of ischemia in this context. So we were interested in this many years ago. We were interested in stroke imaging, and we wanted to see, initially in an animal model, this was in a baboon who had a right middle cerebral artery occlusion. So this is a model of focal ischemia, permanent focal ischemia. And we got a spectrum before occlusion, and then the occlusion was performed, and then we followed the spectrum up to 12 hours after occlusion. You'll see this persistent increase in lactate over the 12 hours. And if you look closely, you can also see that the NAA signal is going down, presumably reflecting the loss of neuronal viability as the ischemia progresses. So the next step was to try and do this in humans, and we were very lucky around this time, around 1993 or so, that we got this multi-slice spectroscopic imaging pulse sequence from the group at the NIH who developed this, Jeff Downs' group. And this, instead of just picking one brain region and getting a spectrum of that region, this pulse sequence basically lets you map out over quite a wide volume of brain tissue the different metabolites. So you can make maps of NAA, you can make maps of creatine, you can make maps of choline. And this was basically done on our standard 1.5T scanner at that time. So one of the very first stroke patients we tried with this sequence, this was a patient who had a right middle cerebral artery occlusion, and we were able to scan him about 24 hours after the onset of his symptoms. And basically, on the T2 weighted image, as we expected, it's basically normal. You really can't see the stroke at this stage on the T2 weighted image. However, when you look at the lactate images, you can very clearly see the elevated lactate through the right MCA distribution, and you also see a somewhat lower NAA in the right MCA territory as well, and also a slight increase in choline in a similar distribution. So this patient was treated and was followed over time. He didn't have a thrombectomy, but through manipulation of his blood pressure, actually was able to reduce his symptomology somewhat. And at the 1 week follow-up, we basically can now see a fairly small infarct in the right caudate nucleus. And there's now, 1 week later, there's only lactate in that infarct itself. But there's quite widespread reductions in NAA and increases in choline. So we felt like this was giving us a lot of information that we weren't getting from the regular MRI scan. So we were quite excited by this, and we thought we could use this to make a positive diagnosis of ischemic stroke and perhaps also estimate brain viability based on the NAA levels, so decide whether it's worth attempting to initiate reperfusion or not. However, it didn't go anywhere because this is also about the same time that diffusion and perfusion MRI was just coming into practice. And diffusion and perfusion can give you very similar information in terms of what you need to know in order to treat. It's higher spatial resolution, it's easier, and it's quicker. So whereas this was a 30-minute acquisition, it was just too cumbersome. So the application of using this for triaging acute strokes didn't really make a lot of sense at that stage. Now, and then this is just a 3-month follow-up, and the infarct is actually pretty small now. At 3 months, it sort of shrunk somewhat. There's a second new lesion just in the corpus callosum, very small. But actually, you can see there's widespread metabolic changes in this patient. So much of the right ACA and MCA territory has pretty low NAA, so it's not normal. Just one more example. So this was a different patient. This patient scanned a little bit earlier, 21 hours after their stroke onset, but this patient has a very large stroke. Both the ICA and the MCA are occluded. So it's basically a hemispheric stroke, and you can see a whole hemisphere full of lactate, and also the NAA is severely depleted at this stage. So basically, one of the messages here is the speed at which a stroke evolves is very blood flow dependent, also dependent on the size of the stroke as well. So that was a long time ago, and there's been a lot of technical development since then. One of the critical factors is, if we're going to get this sort of methodology into a clinical application, is that it's got to be made faster. And this is a fairly recent paper from the group in Geneva. I like this methodology a lot, where they're using sparse sampling, basically 3D compressed sensing, lower rank reconstruction. And this is still actually a fairly long scan. It's 20 minutes, but it's an isotropic 5mm resolution in its whole brain coverage. So it's actually a pretty impressive sequence. And I think with a bit more tweaking, it can probably be got down to 10-minute scan time without too much trouble. So this is still an active area of development. Now, but maybe acute stroke, it's a tough disease to evaluate with MRI, because how often is an open MRI sitting there available as soon as the stroke patient comes into the ER? CT, head CT, CTA, CTP is extremely good for triaging strokes right now. So even the diffusion MRI and so on is sort of falling out of popularity for triaging acute stroke patients. So maybe we need to be thinking about different applications, not acute stroke, but other scenarios where this sort of methodology could be useful. So at the other end of the scale here, this is in babies who have had an episode of hypoxic ischemic encephalopathy. And it's pretty difficult to know at the acute stage what the outcome is going to be in terms of neurological development. So again, actually a quite old study from the group in London many years ago basically showed that MR spectroscopy done between 1 to 4 days postnatal age was actually pretty good at distinguishing those with a bad or severe outcome from those with either normal or mild HIE. And that's based on essentially on the lactate level. So if there's high lactate in 1 to 4 days post-birth, that's generally not a good prognostic indicator. And this has been followed up more recently. This is a paper from a group in Australia where they looked a little bit later on. So we're not talking about 1 to 4 days after birth, but now we're looking at 4 to 14 days. Most babies, if HIE is suspected, the standard treatment these days is 72 hours of moderate hypothermia to sort of protect the brain. So they were actually looking at the kids after they'd finished the hypothermia, but again, looking at the same question as can we predict outcome? They got extremely good prediction of bad outcome as determined by neurological testing at 2 years of age. And lactate was a fairly good indicator, but actually the stronger indicator was NAA. And I think after 4 days, a lot of the lactate may be washed out if there was an acute period of ischemia and then followed by reperfusion. And the other thing I think was important about this paper was that they also compared the diagnostic accuracy of MRS versus a lot of the other measurements that are currently made. So clinical exam, EEG, conventional MRI, diffusion, tensor imaging. Some of them do better than others. Actually, diffusion tensor imaging, looking at the posterior limb of the internal capsule was pretty good. But actually, the measure with the highest area under the curve on the ROC analysis was the thalamic NAA measurement. So I think this could potentially become a sort of standard test for predicting outcome from HIE. Just finally, I know I'm almost out of time. One last study I wanted to talk about, and I thought this was particularly germane to this meeting because the topic is cerebro and cardiovascular disease. And this is a study combining both things at once. So actually, I think as we already heard this morning, there are some congenital heart disease in young children that require cardiac surgery to correct them. And in some cases, this has to be done, cardiac arrest has to be done in order to do the surgery. And obviously, critically important here is to protect the brain during that time period where there's no perfusion to the brain. So this was a study done by the group in Stanford where they looked at the neonatal piglet model of cardiac bypass, cardiopulmonary bypass. And it's particularly cool that they could actually do this whole procedure in the magnet. So they can measure the temperature. Actually, brain temperature is one of the other parameters you can measure from an MR spectrum. But they were also able to measure lactate and creatine and separate it from phosphocreatine very clearly, glutamate, and actually also the glucose levels in the brain. And they actually looked at 4 different models. So 2 different temperatures for hypothermia, either 18 or 28 degrees. And they either looked at total cardiac arrest or they looked at antegrade cerebral perfusion, which is a surgical procedure where you sort of bypass the heart and you perfuse the brain using an external pump. And they found a lot of interesting findings. One was a new finding that during reperfusion, I'm not sure how well you can see it on this chart, but during reperfusion, the glutamine, which is the blue squares, is significantly higher. And glutamine can be, elevated like that, could be kind of toxic to the brain. So that may be one of the things that is contributing to brain damage after this procedure. The bottom line from the study was that the antegrade cerebral perfusion looked much more protective than just cardiac arrest. So I hope I've convinced you that there are many ways that MRSI can be used to investigate brain metabolism. If you administer labels, it can give you a lot of information. But it does require, for deuterium or hyperpolarized carbon-13, both administering an exogenous substance as well as special hardware to do the scans. And the easiest studies are really those that just look at the natural abundance, nuclei and compounds that are already present in the brain. I don't think this is going to be something we're doing in acute stroke anytime soon, but there may be other applications in cerebrovascular disease where this might make more sense in the clinical setting. And it's still very much an active area of research, and there are many obstacles to overcome before it might eventually get into clinical application, but I'm hoping that eventually it will be. Finally, I just want to wrap up by acknowledging all the members of my and Richard Eden's group, our funding from the NIH, and thank you for your attention.
Thank you very much, Professor Barker. Would you please remain on stage, as we're going to invite Professor Cheng Ji on stage to present a souvenir to you as a token of appreciation.